everyone. In this video, we're going to take a look at the steps of the primary assessment. Now, an overview, A, B, C, D, E. Those are the steps of the primary assessment, starting with A, airway. What is an airway? An airway means the air can get outside the body, inside the lungs, and back out, just like a highway. You take a highway to get from one place to the other. An airway means that air can come from the outside into the body and back out. That's all it means. That's all an airway means. Now, how do we get the airway? Well, the patient may need to have the head tilt chin lift, get that tongue off the back of the throat. If that doesn't work, we may need an OPA or an NPA. If that doesn't work, we may need an advanced airway to maintain their airway, the path of air, gas getting in and out of the body. We can also measure that. As far as oxygenation goes, we measure that with our pulse oximeter. If their oxygen saturation is low, our goal in pulse oximetry is to administer supplemental oxygen to achieve an SpO₂ between 94 and 99%. So we measure oxygenation with our SpO₂, our pulse ox. We measure ventilation with our end-tidal waveform capnography. Normal waveform capnography is somewhere between 35 and 45. Next in our primary assessment, B, breathing. Is the patient breathing? Are they breathing adequately enough? What are we looking for? Adequate rests per minute. Are they breathing enough times per minute in their respiratory rate to adequately oxygenate themselves? Remember, we measure oxygenation with our pulse oximetry. And if they're breathing and their pulse ox is low, we're going to administer supplemental oxygen to achieve an SpO₂ between 94 and 99%. So that's all the oxygen going in. Blowing off is the ventilation part, and we use end-tidal to measure that. Again, normal end-tidal is between 35 and 45 millimeters of mercury. Is your patient breathing adequately? If they are not, you can supplement their breathing starting with bag valve mask ventilations. Next in our primary assessment, C, circulation. We want to assess the patient's circulation. Now, if we've determined that they don't have a pulse, we're doing chest compressions. Now, how do we determine if our chest compressions are providing circulation to the patient? Well, one way is we can look at our waveform capnography. And any end-tidal reading below 10 during chest compressions probably reflects poor chest compressions. We need to improve the chest compressions we're providing. Now, if you're up in a unit and a patient has an art line in, an arterial line, a diastole less than 20 also suggests we need to improve our chest compressions. As far as supporting circulation, we may need to administer fluids, we may need to administer medications, and most emergently, we may need to defibrillate the patient if they're in a lethal arrhythmia. And these are the items we're going to focus on during the C phase or circulation phase of the primary assessment. Next in the primary assessment, the letter D, and D stands for disability. Whenever we're talking about a patient's disability, we're speaking about their neurostatus. Do they have altered mental status? And a good down and dirty for this is to use the AVPU scale. AVPU stands for alert, verbal, pain, or unresponsive. So the alert, you walk in, they're looking at you, you're looking at them, patient is alert. If the patient is unresponsive, do they respond to verbal stimuli? V, when you go, hey, and they go, what? They were responsive to verbal stimuli. If that didn't work, you may want to give them a sternal rub, give them a little painful stimuli and see if they perk up from that. If not, the patient is unresponsive. So again, disability speaks to their mental status and the degree of altered mental status. Next, finally in the primary assessment is E, exposure. You have got to expose your patient. And I'm talking about taking their clothes off. You have to. Keep them covered, keep them warm, keep them safe. But if you're assessing someone's respiratory distress, you have got to look at the chest. You're looking for intercostal retractions. The stethoscope needs to go on the skin when you're listening to lung sounds. So exposure may actually come earlier in your assessment, but we're talking about exposure, we're talking about getting them naked. But cover them up. This has been a quick review of the primary assessment. I'm Mark, thanks for watching. See you in the next video.